comes in overnight. And so the mornings are pretty hazy and stuff. Not
And kick this off. This is the Kern Valley Healthcare District Board of Directors. It's Wednesday, October 6th, and this is our regular meeting. So we were called to order. Do we have any changes to the agenda? Okay, I don't see any board member request any changes.
No, sir.
Okay, we need to approve this.
I'll go ahead and move Ross to approve.
Thank you, John.
I'll second since I'm next time.
Thanks, Gene. Okay, so we need to do a roll call vote. So John,
Yes.
Gene,
Yes,
Fred,
Yes.
Catherine,
Yes,
and I'm a yes. So agenda is approved. And flag salute. Tim, could you lead us in a flag salute tonight?
Sure can.
And Catherine, could you do our invocation?
you know, I have a really sore throat.
Okay. Is
I-
Mark available?
I'm happy to.
Thank you, Mark.
Thank you, Mark.
All right. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you, Tim.
For those of you who would care to, please join me. Heavenly Father, we come before you this evening just as a board of directors and concerned administration regarding the fate of the hospital. We ask that you bless the decision-making, ask that you be with us as and guide us and give us direction. We do this work for the good of the community, and we just ask that you bless that work that we are doing. In Jesus' name, amen.
Amen.
Thank you, Mark. Our mission statement is here stated on the agenda. It's there for you to review. And if you notice in that mission statement, we have a strategic plan that coincides very well with that mission statement, and the strategic plan is alive and well and being implemented every day. So we'll move to item C, which is public comment, and this portion of the meeting is set aside for members of the public to address this board on items that are under this board's jurisdiction, but not on tonight's agenda. Does any member of the public wish to address this board? Okay, hearing none, then we will move to item D, consent agenda. And items all on the consent agenda will be heard and approved by one motion and one vote, unless a member of the board or a member of the public cares to request that an item be withdrawn so it can be discussed separately. Does any member of the public wish to have an item withdrawn from the consent agenda? Okay, hearing none, does any member of the board wish to take something off consent? Okay, hearing none, then we'll
make a motion, we approve the consent agenda as presented. Or as
thank you. Thank you, Gene. We have a motion.
I'll second, Ross.
Thank you, Fred. And we'll do a roll call vote again. Fred, your vote?
Yes.
Catherine?
Yes,
Gene?
Yes,
John?
Yes.
And I'm a yes, so all the items on consent are approved. We'll move to item E, which is reports, and we start with our foundation report. I see Debbie Hess.
Good evening. Can you hear me okay?
I can, thank you. Thanks for being here.
So our Crab Fest was a awesome event, and I think we probably are going to have hopefully close to $18,000 or $19,000 that we've been able to raise towards the cafeteria upgrade.
That's fabulous.
So once we get the final number, I'll get with Bob and we'll start looking. We're talking about doing something on the walls and getting all new furniture in there. So Hopefully we're close. We may still need to do some more fundraising. There's a lot of activity that's going to be coming up. As you know, the Heart Walks in February. This is going to be a combination with the district and the foundation. We're going to do a nonprofit expo that will be coming up. We're going to have the chocolate mixer, wine and chocolate. That'll be in February. There's just a whole bunch of things we're going to be doing. Our take back medication, and a lot of these are going to be starting in January through April. And then tomorrow you guys will receive this isn't foundation, but you'll have a press release talking about our new transportation project.
Oh, great. Good deal.
Any questions? Thank you.
Thank you, Debbie.
Thank you.
Auxiliary report. Is Cindy Rupert available?
I'm here.
Hi, Cindy.
Hello. I don't really have a big report tonight. We had to change our Monday hours because there was kind of a catastrophe down there, but we're still open on Mondays, but we're only open from 10 to 2 to take donations and to sell. So it'll be a big adjustment for the public on that part. Other than that, things are moving right along. The gift shop is doing great. Ellen's still providing baskets for the nurses. And that's about it.
Are we, have you been able to get our, the website changed so the public knows what the hours are, or they can look to see what the changes are?
Deb,
I'm sorry, what was that?
he was asking if we get the website changed to reflect the auxiliary's new hours for the thrift shop.
Yes, we can get that done.
Okay, thank you. And I got signs hanging at the next thrift store also.
Great.
Thank you, Cindy. I would love to get with you sometime after the meeting or the next day or two and understand what the catastrophe was. Maybe you don't want to go into the details, but would love to hear about it.
I can share it with you if you need.
It's just lack of membership.
Ah, okay. Okay. That is a catastrophe. All right. Thank you. Thanks, Cindy, for being here.
Everywhere.
Any other board members have questions? Okay, then our medical staff report. Dr. Finstead.
All right, thank you, Ross. The Pharmacy and Therapeutics Committee met on September 20th, and we again discussed COVID-19 related issues, the topic that will never go away. We reviewed and approved 2 policies from radiology regarding the radiation physicist and department hours. We discussed adoption of a protocol for monitoring medication called metformin in the skilled nursing facility. There's some issues with that if people are getting contrast, CT contrast studies. So we're working on that. We reviewed and approved some formulary additions, primarily related to some of the maintenance inhalers for people with asthma and COPD, and things that are very, really very critical maintenance medications. And if people go off of those, they can decompensate. We also have reviewed a number of the reviews on procedural sedation, which is when somebody comes in and needs some medication to basically allow the ED physicians to straighten a fracture, reduce a dislocation, and things like that. So that process is high risk in that we're giving medications that can affect people's airways. So there's a pretty extensive paperwork, forms and monitoring needs to take place. We've had some issues with some of this, these over the past year, and are reviewing those, reviewing the policy. We'll be making some upgrades and stuff like that, or some changes in that. So it's been quite a long time since we've looked at this, and so this is a timely thing to reevaluate stuff. And Mark, from his nursing perspective, is very much involved because the nurses in the ED are critical components of this. In addition to that, we reviewed monthly and quarterly reports regarding blood usage, blood culture analysis, medication error reduction program, and medication shortages. Then the next meeting was the Utilization Review Committee on September 23rd. They discussed denials of payment and authorization for admission. I guess particularly with issues with United Healthcare and Blue Cross. Apparently there's some difficulty getting some of the inpatient admissions authorized compared with observation, which generally pays a considerably lower rate and things. So they're working on that. They also discussed issues regarding the average length of stay. This has been impacted by treatment for COVID. So the COVID treatment takes is an intravenous medication for 5 days and things. And then also the emergency room is a place where families that basically are kind of desperate can bring in family members and basically kind of leave them there because they can't really take care of them. Oftentimes it ends up being more of a social issue rather than a medical issue requiring admission. So that when some of these people get admitted, for maybe a relatively minor medical issue, that gets taken care of, and then there's just no place to discharge them. They're not safe to go home by themselves. So that can extend average length of stay quite a bit. They also reviewed their regular reports, including the utilization review and medical record studies. Then the next meeting was the Medical Executive Committee held on September 28th. We reviewed and approved a provisional appointment for allied health practitioner, a new nurse practitioner for the rural health clinic. In addition to that, there were 5 credential files reviewed and approved for reappointment to active staff, emergency medicine, plastic surgery, and our nurse anesthetist. We also reviewed and approved the radiology procedures along with the additions to the formulary. We reviewed one of the reviews that medical staff does is we review mortalities and things, and to see if they meet criteria. That's probably the best way to put it. This was one from the ED, and we had gotten a coroner's report. So that was kind of an unexpected death in the emergency room, and the coroner's report shed significant light on that. So that helps to kind of get everybody on the same page with what's going on. Again, about the coroner's reports, we have developed a new process, particularly Marie in medical records, the medical staff office. And so we're able to get them now, whereas we had no luck for 20 years in the past.
Wow.
So this is working well. In addition, we discussed the procedural sedation policy and COVID-19 issues. And that's the end of my report, unless anybody has any questions.
Board members, do you have questions?
The new therapeutic pill that's showing promise, they're trying to get emergency authorization to use it. Do you have any insight into that?
No, I don't. The antiviral medication, the oral antiviral medication that has just gone to the FDA, I think is what you're talking about. No, I have no information about that, other than just to know that that's where the process is. We do not have anything like that. All of the treatments, really, except for remdesivir, is an antiviral treatment, but the other treatments, the monoclonal antibody treatments, are not. They don't affect replication of the virus. So this is an antiviral medication, meaning that it affects replication of the virus. And some other viral diseases, particularly HIV and Hep C, they have made tremendously dramatic progress with antiviral medication over the past, decades and stuff. So for both of those disease processes. So it'll be interesting to see how effective, this is and things.
It could be a very positive thing. It could change a lot.
Absolutely. Right. And particularly a pill, it's the only oral medication, that would be potentially, available for that. So obviously, this is an incredibly fast moving field, both with related to the vaccines and other, aspects of treatment stuff. So a lot of information and I'm sure a lot of misinformation.
Thank you very much.
Sure.
Dr. Finstead, you had brought up an issue with, was United Healthcare and Blue Cross where they're pressuring you to make the admissions as observation rather than an inpatient. Probably because it pays less, so they're less on the hook for reimbursement. What kind of power do we have to push that issue so that it becomes the doctor's call and not the health insurance company's call?
Well, that's a tough question. I'm going to turn that over to Tim. He probably has more information, but you're right. I mean, it's, the doctor in the emergency department can decide on a course of action. But in order to actually get things paid for, they have to get approval. And then they just run into roadblock after roadblock. One of the big HMOs in Bakersfield is notorious for that and things. But Tim probably has some more up-to-date, accurate information than I do on that.
Is it an HMO or is it BFMC or is it WellCare? Because WellCare deals with all the companies the same way.
I think you're referring to the medical group.
Okay.
It's they're trying this across the country, in lots of different ways, and again, these are huge corporations that are doing this. We've had some recent success, I think, with Dignity and so forth. We don't see them doing that much anymore. I know Anthem was having issues before, but that was primarily contract negotiation issues and so forth. Those have been resolved with Dignity, and so some of that has died down. It's always going to be an issue for us. Again, we brought up the one medical group that Gene was talking about, and just they are paid differently than we are. They are paid a capitation rate,
Right.
whereby they get paid X number of dollars per member per month, and that's all they get. And unless there's some serious issue, then there might be an add-on to it or something like that. But for the most part, they've got to live within their means of that cap. And so, the issue is that they will go out and they will subcontract with other providers on a cap basis. If they've got enough lives, many of the providers will take a risk and go for cap and so forth. And, it's a question really of just managing the risk, and so forth. So what ultimately happens is that when they deal with people like us, they have to pay us based upon a contract that's on a per visit basis and so forth. Under a cap, a patient can go to a doctor 10 times. That doctor doesn't get any more than what he got for his monthly cap check and so forth. But because he's getting paid for 1,000 patients with the hope that only 50 to 100 show up, that's how the numbers work out.
Right.
So that's the incentive that a lot of these groups are under. They're capitated groups and so forth, and it costs them to deal with us when we're on a per visit basis type thing. So those incentives and those pressures within their organizations are going to continue. I don't see, again, and those again, because they're part of a larger group south of here. And out of LA and so forth, Inland Empire. And so they, like I said, a lot of the pressure for them to produce a bottom line is coming from those places. And the doctors, frankly, I think get incentivized, for their ability to keep costs down and so forth. So, and what we've done is we just, our response to that is we have to appeal, and we got to go for it, and just, we get in their face and say, no, we're not accepting this. If we've got a patient who meets criteria, we try to get the doctors to talk to the doctors directly, and so forth. And we've had some success with that in the ED. Not always, but sometimes we have been, if the doctors feel that they're pretty strongly about that. So it's just a continual fight, and it's not going to go away.
Can we file a complaint with the insurance commissioner and say, knock this stuff off?
They don't have anything to do with the medical.
Yeah.
Observation is not observation, right?
No.
They lay in a bed
Yeah.
and nobody looks after them. They're just closer
Well,
if they have a problem.
the issue is, like I said, what they try to do is they try to put someone into an observation bed saying, well, we don't quite know what this patient's got. So we'll pay you, we'll authorize a observation stay, which is nothing more than an outpatient stay. I mean, so they pay us for the outpatient ancillary services. We do an X-ray, or we do a CT scan, or some labs or things like that. They will pay us our outpatient rates for that, which obviously don't include all of the expenses that we incur in caring for that patient because they're laying in a bed. We've got nursing that has to be caring for them, that have got to
Do
be
they
checking their
actually
blood
get
pressure.
care?
Oh, yeah, absolutely. Mark, I'll let you address how your nurses deal with observation patients.
They don't deal with them any differently than an inpatient.
You have to feed them,
We
you've
can't.
got to take care of their clothing, you've got to take care of the PPE. It's no different.
Right, that's the issue. And this is why we get so upset about it, because like I said, we're expending the dollars for the people to be there to care for them, and they're in essence paying us outpatient rates. And a lot of times what we'll see is they'll do this for the first day or so, because they know that we expend the majority of our funds on the first day, because that's when you're doing your CT scans and your lab tests, all your diagnostic stuff's going on to figure out what's going on. The next couple of days are nothing more than treatment, which is going to be antibiotics and things of that nature, IVs. And so forth, and they know that. And so by only authorizing the first day, okay, now we'll give it to you.
Is most of it Medicare?
No,
So CMS would be one too.
yeah, no, most of it's not Medicare. So it's more of the managed care plans and so forth.
What Mark said about the nursing care holds true for the physician care too. Once the patient, gets into a bed on acute care, whether they're an acute admit or they're an observation, there is no difference for the nursing care. There is no difference for the medical care. There's no difference in documentation. It makes zero difference, what we do for the patient. It's just a money thing.
It makes a difference to Barbara.
Yes, right. Right. Fortunately, she works in a different building.
Doesn't have to see it, right?
The observation, I always thought it wasn't acute care. It was just a place for them to be there
That's what it's supposed to be.
without any care.
Yeah.
And so.
This is one of the
they pay
reasons.
less.
This is one of the things that happens, like I said, is most hospitals weren't designed to have observation beds, okay? And so what most of them have done is they've taken some of their inpatient beds and put these patients in there. Technically, by law, we're not supposed to mix inpatient and outpatients in the same beds, in the same unit. So what CDPH is doing now is all the seismic stuff, these corrections are being made to the hospitals. They're coming back and mandating that we put observation beds in our ER, because technically that's where they should be holding, because they're ER patients that we're not quite sure what's going on with them. You hold them there to make a decision, and then if they meet criteria, then you admit them. So that's one of the reasons why they're pushing
It's
back.
ever changing, it sounds like.
So Tim, are there any rules against us upping the rate of our observation bed costs to make it equivalent to an inpatient?
Well, the problem is because you're charging outpatient rates, the outpatient rates you would be charging would be impacting everybody else who's coming in for regular outpatient care. So, that's what I say, you're kind of damned if you do and damned if you don't. So like I said, our best strategy that we've seen so far is literally just to appeal them and just continue to do that. And it takes a while. I mean, they understand that it draws out. It can take months to get an appeal back on a case,
Right. Yeah.
and so forth. But, and they know that a lot of facilities won't fight that, and so, But, like I said, when you've got one that, really needs to be done, then, we need to, get on it. And Dr. Gross has been, has written letters to the plans and stuff like this. And I'm sure Dr. Finstead has as well. And, so it's just one of the things that we will continue to do. And
A lot of those are capitated rates, you said.
some of them are, yeah, some of them are. Like I said, the plan is capitated, like I said, but when patient comes here, they've got to pay us our per diems and stuff like that, that we're contracted with them for.
I know back in the day.
So that's why they want to do it on an outpatient basis.
I know back in the day, we had a capitated contract with the FMC. And
Yeah.
it was a nightmare, though. I'm sure Barbara probably remembers that
Yeah.
quite well. But
And it's not unique to us. I mean, this is all the hospitals are getting hit with this stuff, and so we're all battling with it. But and like I said, you mentioned making phone calls up north. People have been doing that forever with little to no success.
Okay.
It's just it really gets down to finding it at the provider level, from doctor to doctor, and so forth. So. Hopefully.
Okay. Thanks, Dr. Finstead. Thanks for sharing that.
Oh, you're
Frustrating-
welcome.
That frustrating part of your job. That's really maddening. Any other questions or comments for Dr. Finstead? Thank you, sir.
All right, you are more than welcome.
Okay.
Thank you.
Our Chief Executive Officer report, Tim.
Yay. I'm just gonna kind of go through some stuff quickly. The COVID, obviously, we are, the situation that we were most concerned about recently was the mandatory vaccination of all of our staff. Or, our staff had to apply for exemptions, or they had to leave us and so forth. Out of 240 employees, we had 187 get vaccinated. We had 48 of them who are exempt. We've got, I think, 3 that are pending, and we've got 2 that are no's at this point. And it's more because we haven't been able to talk to them or reach them and stuff like that. So, I mean, really our critical situation at this point is 2 people. We have, like I said, several that have gotten their first shot. We're waiting for the second shot because you've got to wait 4 weeks before you can get that second shot and so forth. And so we're working on those, but for the others, the vast majority of our staff has been covered either through the vaccinations or through the exemption process. So I think in comparison to the other hospitals in Bakersfield, we've done remarkably well in that. I know one of the hospitals down there was looking at close to 63 or more people to be terminated. I know one of the other hospitals was right around the same mark. Another one wouldn't tell us how many they had because we know it was considerably more than that, and that was Memorial. So again, it's hit hard. I think every one of them, and ourselves included, to lose one employee is tough. And so this was just I don't even want to get started on it because just to get angry about it. But it's just a ridiculous process. And like I said, we certainly understand the benefits of people being vaccinated. We strongly encourage everybody to get vaccinated. But like I said, it's just, when you're in the middle of a crisis like this and you put these things in place that force us to potentially remove staff when you desperately need them, and that there are significant nursing shortages going on, and registry wars and these kinds of things. It's just was a really bad thing to happen. But like I said, I'm extremely appreciative of our staff, with Greg and all of his people, and each HR, Deb Hoffman, literally going through and corralling everybody, trying to get the word out to, get their forms filled out, and, and so forth. So I feel very comfortable that we did a great job, in that matter. At least, our biggest issue is to keep people working. We've got patients that need to be taken care of, and we need people to do that. And so, like I said, I think we've done the best we can. We are still, continuing to try to bring on some additional staff. Mark has been out trying to recruit I just heard today we were successful in recruiting it's a registry traveler for physical therapy for our one that left. And so that will certainly help them down there. And I think Mark's got some things he's working on for ED and elsewhere on acute side. So again, we're just going to continue. It's just an ongoing process, you know. It's just and it's just that much harder in the rural community. But people just seem to keep popping up for us, and so we're working on that. We got another one we just got is a pharmacy one, I believe, that is in the process. We're negotiating with them right now. So like I say, we are finding some new staff. We did renew the contract with the county for our COVID testing. And that will continue on at this point through the end of December. You know, we've been still seeing pretty good numbers coming through there. You know, we had 73 today. I think we had 80 last week and 102, 108 week before that. So, I mean, the numbers are beginning to slowly come down a little bit. I'll let Mark talk about that some more. But you know, it's still with us. We just have a tendency to be a week or two behind Bakersfield. They started coming down last week. And like I said, I think we're just kind of peaked out. We're now beginning. I know we've had the other day, we had a pretty significant day in the ER with a bunch of COVIDs and so forth. But again, the staff handled that really well.
Tim?
Yeah.
The rhino flu, when you're doing the testing, if someone has a rhino flu, which is supposedly pretty severe flu, and they go for testing, does it tell if which they've got or how?
I'm going to defer to Greg or Dr.
Testing specifically for influenza.
What's that?
They're separate tests
Okay.
So you have to suspect that it's rhino. Is there different symptoms or?
for influenza.
Yeah.
Yeah.
The right, I think.
They're separate tests.
Do you? Okay, so if they're negative for COVID, then they probably got rhino.
There's a lot of different viruses, other things that bacterial infections that can cause different types of symptoms. So every situation is different. The ER is really good, especially about doing all the appropriate tests that need to be done.
But the people that are showing up because they're sick, they don't feel good.
Great.
Does that turn out to be COVID?
I think, Mark and Dr. Finstead can answer that better about what's going on with testing in the hospital.
So Gene, when somebody comes in, say with a respiratory infection, you might say maybe you're suspecting influenza. So there's only two things that we can test for. One is influenza. There is we can do a rapid influenza that'll tell us if people have influenza A and influenza B. It's not terribly accurate, but it's useful. And then the other test is the rapid antigen test for COVID. We also can do bacterial cultures, but those are rarely done for upper respiratory infections, and it's notoriously hard to identify, say, a pneumonia, to identify a bacteria and things. So we really, our ability to test and tell what things are is actually very limited. So we treat them empirically, which means we use our best judgment along with historical information about what tends to work best for people, say with an upper respiratory infection or a pneumonia and things, a community acquired pneumonia. There are established guidelines for that. But our ability to find out exactly what's going on is extremely limited.
Okay, thank you. I get the picture. You do the best you can.
Yeah.
Right, exactly.
So Gene, I do the statistics. I've been doing them for about, 12 months now. We've had 2 positive influenza cases in 6 months. 2. And usually the doctors in the ER are testing for COVID and rapid influenza on the same case because they're presenting with very similar symptoms.
Cool, that's
So
really
to
good.
say that it's one or the other is really hard to do.
Yeah,
I would say it's probably not influenza because we're just not seeing a lot of it in the community.
And we didn't do it last year either because, so many people were wearing masks and so forth, so it wasn't spreading like.
Yeah, it's good. It's
Yeah.
awesome.
So this year may be a little different because people started not wearing masks, so we'll see.
So I have a question, Mark. Do we
Sure.
keep statistics on those that are vaccinated that come up with a positive COVID test?
No. We
No.
just started looking at that. Catherine, I just actually added that on to the bottom of the form. It's actually asking if you're vaccinated. They don't have to answer that question, so it's not going to be terribly accurate, but
All right.
it's a good question though. I had that question about a month and a half ago
Yeah.
when we
Well,
started seeing a lot of positive cases in the vaccinated.
I mean, we report all positive cases for COVID, daily, to the state and the county, like we're supposed to, so I mean, they're the ones that are really keeping those registries on total numbers of positives and stuff. Wasn't quite sure where you were going with your question there, so.
Yeah, I'm sure I could give you 10 names today if you wanted,
Yes.
but
I know exactly what you're talking about.
yeah, I mean,
But the
it's
same
just,
thing applies. Would they be sicker and admitted to a hospital or an intensive care unit were they not vaccinated? That's I think what the real
yeah,
question.
and I understand that. It just is kind of amazing that we mandate someone to get vaccinated in order to work when they
Doesn't
still,
work.
yeah, it doesn't work. I don't know how else to put it, but thanks. Yeah, when it doesn't work. So, okay, just, I'm glad you added that to the question there, and I'm sure you'll get probably more answers than we expect. I hope.
Yeah, we'll see. I hope so.
Thank you.
Mark, can I make a comment?
Sure.
You have one wonderful emergency room department. You guys are awesome.
Thank you.
Thank you.
Yeah, we just never mind. I'll talk about that in my report.
Okay. As in regards to flu vaccines, we have received our high dose vaccines. Those are the kind of the double dose vaccines that we try to give to seniors. This is the first year we've ordered those. We've got those primarily for the SNF. We actually have more than we will need in the SNF, so there will be some that will be offered to the public.
That's regular flu shots.
They're the super shots for the flu vaccine. And then our regular flu doses are due in tomorrow, I believe. And so, we'll be once we receive them and have them in hand, we will be coordinating, a drive-through for the flu vaccines and stuff as well, as we have in the past. So anyway, that's going on. Pleased to report that we did receive a notification from Beta that we've gotten $172,000 rebate coming to us. Half of that came. I think the rest of it's due in April 1st of next year. And that's primarily on our liability claims. Let's see here. I did sign an agreement with Kern Health Systems. This is a vaccination incentive program for our physicians, our clinic staff. Primarily, they're willing to pay our staff to continue to vaccinate their membership. So it's based on a certain percentage of their members that are positive or that are unvaccinated in our areas, and to the extent that we can boost that up, they can get up to $50,000, in incentive payments to do that. So we're going to be trying to figure out how we're going to do that. We did agree to do it, and so working with Deb and Greg on that one as well. And there's incentives built into that for the patients themselves, obviously. So they recognize that, again, the more people vaccinated, the better. And so, like I said, because they're one of our primary, health plans up here, and so forth. And again, they've been very good to us, as we've seen with our transportation program and everything else that Mark will talk about. We try to do everything we can with them. We're also working on trying to reach out to them to do some more wellness programs. Deb will be talking with them shortly about doing some things. One of the grant monies we received, we're really part of an overall program to improve patients' health, Medi-Cal patients' health within the state. And there was a whole range of programs that we could elect to do to participate. And like I said, Mark put in for the transportation and got that and so forth. But there's other things that I think that would certainly benefit our community. And so that's what we want to see if we can't sit down and go over those with them and see if we can possibly work something out to jointly do something together on that. We did receive a new grant for telemedicine equipment, participated in that with about 15 other agencies. We received word from the FCC that we were approved. So that will bring us 5 new telemedicine carts. And so we're working out the details on that shortly. I am not happy to report that Tushar Joshi, our retail pharmacy manager, has stepped down and left the organization. Again, he was commuting quite a distance to get here. And so, he has taken a position closer to home, and that I think works much better for him and his family. And so we wish him well. CCON is already working on a replacement for him. And so, and just obviously keep some of the great programs that he set up down there as well. So that's, we're moving forward with that. We're not going to let his efforts drop. And then I know we're working on, Barb and Dave are beginning to work on the next round of provider relief funds that were made available. I believe it was about, was it Dave, $18 billion or something like that, which 8 billion or something like that is going to be
total of 25 million. 8.5 is available for a new specialized area for rural called ARP rural. And the nice part about that is it's going to reward, they're putting more dollars into the rural pot to especially busier rural hospitals, which I think Kern is compared to a lot of other smaller critical access. So I think we're in good shape to get a pretty sizable number if we cross all our T's and dot all our I's correctly and get that application in.
Great. So that's underway. The leach field, you've seen obviously the construction going on out there. The 24 pits have all been installed. The piping has been started to link all of those together. They'll be back tomorrow to continue some of the piping and to feed that into our lines coming off of our water treatment system. And so the hope is that by next week or no later than the following week that they will actually be out, hopefully beginning to pour the concrete again and resurface that out there. And so, like I said, we had a very critical situation here before. We have 2 existing sets of leach field pits out there that had backed up because they were not properly installed years ago and so forth. These are substantially better and bigger and so forth. So we should never have a problem with this again. And then last thing, just really was reporting that the CEC, the California Energy Commission, has in fact released our final check for the project that we did for all of our light retrofitting and the boilers and the chillers and all that stuff that they were holding on. And I think it was about 360,000 or something like that, thereabouts. And that's my report.
Thank you, Tim. Board members, do you have questions or comments for Tim?
I don't have any questions, but thank you very much for all the information.
You're welcome.
Yeah, thanks too.
Tim, it's probably too early, but do you have a date yet on the drive-through flu clinic?
No, Heidi controls that.
Okay.
Controls that we're scheduling until we actually see the vaccine in the facility. It'll likely be the end of October.
I tease her about that. She's been involved with that program for a long time.
All righty,
Yeah, we want to make sure that we actually had vaccine in hand before we announced anything.
sure.
So, and that, like I said, supposed to be here tomorrow, so we'll see.
Some
right.
super flu shot you were talking about, you have to prove that you're a senior.
You don't.
Just show up. We know better.
You're what, 185 years old now?
All right, thank you, Tim.
You're welcome.
Okay, we'll move on to the Chief Nursing Officer report. And Mark Gordon is just walking away.
He's done.
Forgive me. Sorry, I had to adjust my collar.
Yeah. Can't believe you did that.
So yeah, we are seeing a resurgence of COVID in our community. Our positivity rate last week was around 15%. It had gone from 24% down to 10%, and now it's back to 15%. We ran 73 through today, or 72.
73, yeah.
And we'll know by Friday or Saturday the results of that. But of more important, we have applied for, or we filled out an order for Regeneron several weeks ago, and we found out that the federal government decided to start controlling the distribution of Regeneron. So they pulled in all the stockpiles and then started distributing out to the states. The states then would distribute that out to the counties, and the counties then would distribute that out to the various areas within their jurisdiction to, so we had actually ordered 20, that was canceled. We ordered 20 more, that order was canceled. So for a couple of weeks, we didn't have any Regeneron at all. So we had to borrow some from Ridgecrest. I think we borrowed 12 doses and we promptly went through those. We have since received 2 shipments of 12 doses each, and they have also released some what they call atazivimab, which is what they use as a cocktail with bamlanivimab, which we had 125 doses of, but they pulled it off the shelf because it didn't work for the Delta variant. Anyway, it's all kind of technical, but we have monoclonal therapy now in the building, and I think hopefully we'll have enough to manage the cases that come through the ER. Tim had mentioned on Monday, there were 29 patients that came through the ER. 12 of those were tested for COVID, 7 of them were positive. That's our highest positivity rate to date through the ER in a 24-hour period. So that, I think that I want to just take just a minute to put into perspective the tight quarters that those nurses are working in and doctors. The fact that we're taking care of COVID positive patients in a area that shouldn't be used for that purpose. And we're not having staff coming down with the positive results. We've had a couple of positives in our staff, but for the most part, they're very well protected. They have plenty of PPE and they're doing the right thing. So I just want to put a shout out to the staff back there. They're doing a really good job of maintaining their environment, I'll say. Thanks to Bob for putting a negative pressure isolation system in our front room so that we can keep that air washed and filtered. I do believe that this Delta variant is an airborne strain. I don't know if I can prove that. I don't know if anybody can prove that, but I don't think it's the same strain that we saw in the first go round where it was considered contact or droplet precautions. I think it's more airborne now.
Mark, I would just throw in there that I don't think there's any question about it being airborne. It absolutely is.
Okay.
Stuff, yeah, yeah, and that's one of the reasons why it is so much more contagious and things. So, and I would agree with you about what you're saying about the ED staff and nursing staff back there. It's amazing how congested that can get.
Yeah. So yeah, I also petitioned Tim recently that I'd like to order one more of our of those machines that create the negative pressure washing of the air. I asked Christine to look for that. It's going to be $4,000 to $5,000, and we're going to try to order one of those very soon, and you'll be hearing about that. It'll come through soon.
I was just telling Cindy, we're gonna probably hit her up for that one, so. Just giving her some advance notice.
You should tell Gene we're going to hit him up for that one. All right, so the modified visitor restrictions continue. Family members are, they're not happy, but for the most part, they're cooperative. We still have to remind people coming into the hospital that face masks are required for anyone entering the hospital. Some people give us grief about that, but it doesn't really matter. That's the rules, and they have to follow those.
Mark, real quick while you're on that, do you want to talk about what they're doing over in the SNF with regards to the Zoom calls, for the residents over there? They've got prescribed times.
Yeah, we've actually had a few issues where family members have concerns about not seeing their loved ones because we had all the positive cases over there. Well, we've been able to implement, with Carrie's help, the ability to do Zoom sessions so that families can at least visit with their loved ones on a video conference call. So Laura Springer, she's our activities person, has organized timed calls for all those family members. And she's done a tremendous job to get that happening. The family members seem to be happy about it. And I think it's a good thing for what we're doing.
And they're scheduled, so they know when it's gonna be, so that's the nice part about it. It's at their convenience, yeah.
Wonderful.
We do have a single point of entry to the hospital with that new, we're also considering a new position. We're looking at the job description. I think we finalized that, and it'll be heading to the next board P&P. We do have a person sitting at that desk for at least 8 hours a day to do pre-screenings for people coming into the hospital.
It's gonna be our greeter position, that's right.
The transport vehicles are here, and we've put in the proper documents to get reimbursed for those. Barbara will be happy to hear that. The driver is oriented. Boy, that sounds weird, huh? The driver is oriented. Good thing. And he'll begin marketing and organizing the startup. I think Deb has touched on that a little bit, but we're going to put out a preliminary coming soon kind of a flyer, I think. We do have some legwork to do with CDPH for licensing and for current health systems application to get reimbursement processed.
Oh, you
didn't?
I was gonna say, we got an email tonight from CDPH. They're not the ones that do the licensing. It goes through your county EMS.
Right.
So
I did see that. Yeah. Yeah. So I'll be in touch with Jeff Ferris, or actually Ross Elliott, first thing in the morning. Darn, Ross isn't there anymore. So the one other thing, let me go back to the ER for a second. There was a representative from Devin Mathis's crew here today, and she presented a certificate of appreciation from Devin Mathis to the emergency room staff for all of their efforts during these times. I thought that was a special consideration. So I'm having Tina post that certificate in the lobby of the emergency room.
Perfect.
I think Debbie, Deb Hess, you should probably kind of get a picture of that and maybe put it out on Facebook. But
Put on a nice plaque or something like that,
yeah, it is there.
Right, that really is great.
So the other thing, and Greg Davis was really instrumental in this, new efforts have been put into place to ensure mask compliance in the facility. I happen to know that I was at a fundraiser dinner recently where there were about 3 people or 4 people in a room of about 100 that were wearing masks, or at least trying to wear their masks. It was, I think the community is a little complacent with mask and hand washing. I think most people are getting kind of tired of COVID and they just want to deny that it's even happening, but it really is still among us and we need to be mindful of that. So we're putting in some new efforts. Tim's going to be talking to each manager individually to make sure that their departments respectively are complying with the mask mandates within the building. So those are my comments. And if there are no questions, that's it. That's my report.
Board members, you have any questions or comments for Mark?
No questions, but thank you very much.
Yes, good job.
Yeah, thanks, Mark.
Oh, Heidi, did you want to bring up a picture of that van? You don't have to, but.
I thought you were going to skip it, but.
This is the wheelchair one.
Oh, very nice.
Well, that's the wheelchair van. It's got a ramp that comes out of the back. And those are where the decals are going to be placed. The small lettering says non-emergent medical transport on the side. So thanks, Heidi.
Is that the one from Tennessee or wherever it was?
Yes.
Okay. And you can speak slower when you're driving.
I was just there a few weeks ago. I could have brought it back.
Yes, I know, I used to live there.
We talked about something like that, but they didn't want to put the miles on it.
So Mark, on those transport vans,
Yes.
Unless the rules have changed in the last 5 years, the county does not regulate those. There's no ordinance in place. So Jeff Ferris may kind of scratch his head and go, not ours.
That's where CDH was pointing us. Yeah.
Yeah.
Fair enough.
The only,
Well, when I talked to Kern Health System, she said, because it's going through your hospital, licensing has to give it their blessing. I talked to Jean Chang and she scratched her head. Then I talked to, anyway, I got the runaround today all the way up to Sacramento and back.
Yeah.
But I'll call Jeff just to close the loop on that. And then
definitely. It falls through the cracks. It's completely unregulated except the CHP.
You know, Mark, we've got our meeting with Erin on Thursday. Tomorrow, we can maybe ask her, because they've got the transport out there as well. She might know.
Okay. All right.
Yeah, you'll need some kind of blessing from CHP, but that's it, Mark. It'll be easy.
We got that already.
Okay.
Thank you. It's a VIN verification, I think.
Okay. I had heard on the news today, and I don't know if maybe it's too premature to have gotten anything, but there apparently is there was some internal Homeland Security memo that was discovered or released about healthcare facilities, healthcare workers being the target of domestic terrorist attacks. And I wondered if you've heard anything about that yet.
Nothing that I haven't heard a thing.
Okay.
What are you doing?
What are you doing there, Scott?
Scott, was that a result of my comment?
Were you being terrorized domestically?
I was being terrorized by a spider that dropped right in front of me.
That was pretty.
Sure.
That was pretty perfect timing.
It was.
Well, I was all thanks to that spider. I had nothing to do with it.
The nano spider, don't worry about it.
Yeah, I don't know what that means or what it may. I don't know if there's any intel that'll get shared with us on things that we need to be looking for. But I'm glad that we have security personnel on site.
If there's anything to that, I'm sure they'll be hearing something through the hospital council here very shortly, through the hospital station. We'll let you know.
All right, thank you. Okay, then let's move on then to our Chief Financial Officer report. Dave.
Thank you. So Heidi's going to set me up here, and we're going to do a shared screen. As soon as I find the right one to jump onto. That's not it. So we practiced this morning, and I thought we were going to be able to jump right in to the presentation, and now I'm not finding it.
Yeah, but we're reading your email.
So I'm returning to the meeting and resume share. So I'm going to stop my share and ask Heidi what we're doing wrong.
You need to open the document that you're wanting to share.
So how do I do that?
Go to the email.
I have to go to the email and
Are you
open.
going straight to the financials? I mean,
So,
The packet for the meeting was what you had up this morning.
oh,
okay, so
go to the meeting notice and open the packet.
I'll go to the meeting notice and go to the email that invited me to the meeting.
Down the bottom should be
And
there.
here's my packet that I should have had opened up ahead of time. Next time I'll have that nailed down.
Don't worry, Heidi will train you.
So so I needed to be at the finance page. So turn to page 15 as the cover page. So can you see that?
You can share your screen.
Share the screen. Yeah.
Oh, how do I do that? Let me see.
Bottom.
I have to go back into the bottom and now share, and now go into the report. Okay, now can you see that?
There you
Yes.
go.
Okay.
Got it.
Now can you see my arrow pointing on page 2A?
Yes.
Yeah.
Oh, wonderful. So I apologize for the learning experience on live here. So we're going to start out by moving to the executive summary, page 2A. And right in the middle of the page shows a nice bottom line, actual 1,025,000 with a budget of 123,000. So the only comment I want to make about that is probably about 250,000 of that 900,000 favorable variance that was from prior year. In other words, what we thought was the net surplus last year was probably understated by about 250,000 based on some IGTs that came in late in the year that we decided to post to, I believe it was to the July financials. So we're still doing very well. Obviously, we're way more than 250,000 ahead of budget. Even with that, we're up about 900,000. The next thing I want to refer you to is the volumes are all pretty much all favorable, actual to budget. You can see acute days at 259, 193. The emergency room, because of the COVID, obviously people are coming and getting tested and using our ER. That 1356 number represents about a 10% favorable variance to budget, but maybe more importantly, about a 16% favorable variance to last year in August, year to date, August, the first 2 months of the fiscal year. So we clearly have had a busy summer so far, and it's also contributed favorably to our bottom line. The next page is a new one, and Heidi tells me those of you that come to the meeting don't get a chance to see the color. So now you can see these new graphs. The one comment I want to make, you can see favorable trend there on the financial strength index every year since fiscal 19, heading in the right direction. And that's an adjusted number, which could even be higher if we would have used the year-to-date profit margin. So we're in good shape in terms of the overall financial strength. On the net income, I just wanted to highlight the fact that we really have a positive trend on net income as well. It doesn't look that way by looking at the 21 bar, which is slightly less than the 20 actual for net income. All I want to say about that is that's the unaudited number. We haven't completed our audit yet. And Chet was very conservative in what he put on the bottom line. So I'm thinking that we could easily show at least a better number at the end of 21 after the audit, if we, depending on what Rick Jackson wants to do with some of the amounts that we're currently showing as still payable, but in many cases, we could easily have good justification to move those into showing it to be part of the bottom line for last year. So my point in saying all that is that we're on a favorable trend, and that bar doesn't really mean that we had a worst year, that we did not do as well in 21. That's not really the case. Any questions on any of these graphs? I did put a new section here at the bottom, positive takeaways and negative takeaways.
That's very helpful. Thank you for doing that.
And it's not quite as meaningful this month, but I do like doing a summary like that. What I would highlight at this point is that the number 3, that we're managing our labor costs well compared to the increased volumes, and that's helped our bottom line. And the 900,000 favorable net income variance. Probably the one negative that might need a little bit more looking at is number 2 on the negative. The accounts receivable is high. That's up to over 28 million. And I think I took a peek at the September number, and that went even a little higher. So I told Tim I'm willing to make a few visits out there to meet with the staff and the leadership in the billing office to see if there's any help I can give them in more mentoring and supports to get those numbers back down again.
Sounds good.
Dave, I had a couple quick questions, if it's okay.
Sure.
Yeah, I really appreciate the new sheet that you've done here. It's very transparent, and I don't know for the other board members, but for me, kind of looking at graphs and kind of comparing and contrasting every fiscal year is a little bit easier for me, but that's just me. When I was at the finance meeting the other day, since I'm not officially on that committee and I can't ask questions, but I think you mentioned that there was a possibility that the IGTs this fiscal year might be less than the previous fiscal year. So
yes,
just trying to look forward. When I look at the adjusted financial strength, the ratio, the 1.4, even though it might, the IGT might be going down, do you think that the financial strength might kind of still stay steady above how it's been the last few years where we had a negative number? Or
I think that's an excellent question. I think that's a valid point. And I think I kind of reflected that. This bar right here, you notice that's my projected number, how we're going to finish the next year. And it's not quite as good as the prior years. It's still a good number.
Again,
but
not adjusted by the
we're
audit.
not going to benefit as much this year because the IGTs will be less. So that is a good big picture for a board member to really understand. Yes, we've had a lot of success. We're still doing well, but we do have a few things that are going to hurt us in the current fiscal year.
And again, remember the rationale for that being less this year is because the state is moving to a calendar year fiscal year. So we're getting half the year of the IGT.
You did mention
the following year it will pick back up again.
Okay.
So it's a transition period that we're supposed
I
to.
admit I forgot that point that they were doing.
Yeah.
Now I don't want to scare anybody because it still could be a real positive year. For example, this new phase 4 is also supplemental money that will be added to our bottom line that could add another 7-figure amount that we don't even know for sure that's not even factored in any of these numbers.
Right.
So it's going to be a moving target. We think we're in good shape. We may not be quite as good as last year, but we're still in a real healthy financial picture based on all the major key indicators.
Dave's, some of the money that they might take back, is there a possibility that the advance, or whatever, that they could redirect that money and give it to us in a different form? Is that?
Yeah, you're right, because that's all political. That's when Congress gets together and some of their constituents start complaining because certain hospitals are really struggling. You could see the pendulum swing both ways, back and forth. They take back money, and then all of a sudden they realize they took back too much, and then we could get that money back in a different way down the road. So it's going to be an ongoing moving target in terms of the political environment.
Yeah, well, I voted the right way, so we'll be in good shape.
So the balance sheet, we talked about the fact that AR, the 28 million number right here, you can see is higher, about 2 million higher. The other thing I pointed out at Finance Committee, cash is down the 200,000 on line 1. The corresponding number that makes cash down was the 400,000 that we spent on capital, that 413,000 increase in capital. A lot of that was new lab equipment, and then the van as well. So that's one of the things that caused cash balances to go down. The one thing that you'll hear more from me about in the future that I spend a lot of time looking at, because I'm not seeing as much documentation as I'd like to see to support this line 10 number of 13,367,000. Theoretically, if that's an accurate number, that would mean that Kern Valley that's how much money has to be taken out of our bank account to pay existing liabilities. And that's probably not a very accurate number. That over time, I'm going to work with Rick Jackson and make sure that we have an accurate picture of what our due to third-party payers is. The good news is it's a conservative number, so we're definitely haven't portrayed the organization in a too favorable of a light. In fact, we've kind of been pessimistic in showing a lot of the money coming in not really going to the bottom line.
You're on page 20, right? You changed pages on it. So
oh, I'm sorry.
We're still on the asset page, so.
We're still on, we moved the liabilities, page 20, and we're talking about line 10, due to third-party payers. Do you see that number of 13,367,000?
Yep.
So that's a real high number. Normally at other hospitals that I work, we need to have good documentation of what are the specific amounts that have to be paid back and why, and from a legal perspective. So I'm going to be working with Rick Jackson and our auditor on that to make sure we have a number that we can feel good about in terms of being accurate.
Good.
So to give the prior CFO credit, he wants to be careful because until you know for sure you're going to be able to keep money, it's always safer to not show it as income, and he's doing it the right way until we're absolutely sure.
Chet's middle name is conservatively pessimistic.
And my intent is not to throw him under the bus. I can tell by looking at all his work, he's done a great job there, and really needs to be applauded.
Are we still working with two of you? Or are we stuck with you?
I'll leave that to Tim. I'm happy to be on board, and we're just going to take it 1 month at a time. So now I move to page 21. I should ask before I move to the next page if there's any questions. So I'll get back into some good habits instead of get going too fast. We're not in any race, even though there is a ball game tonight. I don't know, are the Dodgers winning? The Dodgers Cardinals playoff game. Anyway, the current month, the numbers very favorable on the top line. Number 6, gross revenue, 8% over budget, while expenses were 5% under budget. So that's a great combination. I don't have anything major to report on in terms of variances that are of concern. Most of them fall pretty close in line to what happened last month and the way things are budgeted. So I don't have anything more to say on page 21. Page 22 is that same picture, except looking at the year to date for 2 months. And again, what impresses me the most is the managing of costs, 285,000 below budget in operating expenses, even though we're having a busy year. So that's kudos to the managers and the departments that are keeping their costs down, even though we know a lot of the costs are higher this year because of COVID, especially in lab and in contract labor. Any questions on page 22?
Tie ball game, Dave, 1-1.
Oh, okay. Thanks for the update. I'm not so much a Dodger fan as I just hate the Cardinals. So I'm glad.
Go Red Sox.
Yeah, Red Sox looked good yesterday.
Yes, they did.
I don't have anything I'm going to talk about on the next 2 pages. We're moving along. I'm going to try to pick up the pace here and move right on to the supplemental reports. So if you all can turn to page 29. Normally these supplemental reports, I'm usually not going to take the time at the full board meeting. If you want to hear about these, normally I'll do it at finance committee, and I was pleased to see all the board members at finance, and I'll spend the time here. But because we were having technical troubles last time, I'm going to go through this again tonight as briefly as I can, because there is an awful lot of information and some of just a handful of key points that I want to make on these 2 slides, page 29 and 30. So we have about a little over $1 million a month operating budget. So, $15–20 million operation, but you have a high percentage of the dollars flowing into the organization that are in the category of supplemental. So you can see these numbers in the far right column. 2 years ago, it was almost $20 million that came in that didn't fit the traditional way you think of hospital revenues as a patient coming in, getting treated, we bill their insurance and we get paid. This is something completely different from the traditional way hospitals normally get paid. The unfortunate part about the industry as a whole for hospitals is a lot of hospitals have grown to rely on supplemental money. And when supplemental starts dropping, you see some hospitals in real financial danger because they've grown to be reliant on those monies. Thankfully, this hospital has put a lot of that money aside, and now you're going to do a new building. So that's been a good way to treat the extra supplemental money by having a plan to improve the physical plant. My point on this first slide is a couple things. Is the trend that this current year we're only expecting 4.8 million in IGT. Most of it's coming from the IGT category here. You can see this column here going down dramatically from 7.2 million down to 4.1 on the IGT payments for this year. This is cash coming in the door that may or may not hit our bottom line. If you see a description in this box, in this whole row labeled payables, what that means, it didn't show up as profit. We're holding it back until we know for sure, we don't have to pay it back. So we're not showing it, we're not adding it to the bottom line yet. So that's why that one balance that I showed in due to third-party payables was like 14 million, because a lot of this money that has come in hasn't been determined yet to be not to have that we have to pay it back. So the way what you see on the financial statements that I have in this lower right corner, this is typically what you'll see on the current profit loss statement, the format. And for last year, what we showed in the June report was line 11 being 29,513,000. My point on this part of the presentation is out of that 29 million, only 24 million of it is traditional revenue coming from third-party payers for patient services. So, and that's where the other 5 million that hit the bottom line comes through on supplemental. So the good news for this year is that a lot of this COVID money that hasn't been put into the COVID HHS, that's this first column here, none of that has showed on our bottom line yet. We're holding back on all that. You know, could very well be posted to net income in future months and years as we get confirmation that we prevailed by showing adequate documentation that we deserve to keep that money. And so far it's going real well. I'm spending a very high percentage of my time working on those reports to put our best foot forward and show and put the money in the right buckets to show that we have had significant losses due to COVID based on what the quarterly trends that we've been able to show. It looks close to the 5 or 6 million in losses that we needed to show so we don't have to pay it back. That's still tentative, but right now it looks pretty good. The second report, so any questions on page 29?
No, thank you for putting into perspective, Dave. It's really good.
Much better.
Okay, so now I'm going to move to page 30. 30 is just more of a basic report that I was going to start out doing because this was my first meeting. I didn't want to get too complex. Anyway, I did 29 anyway. But on this analysis here is we're just showing, we're trying to highlight what departments have really taken off due to all this COVID business, what departments are affected and what's the magnitude in terms of dollars that are coming in on revenue side. And when the ED gets busy, patients come in and they need tests done. Departments have a lot of extra work to do. A lot more. You can see this line right here, observation patients. We talked about that. There's a lot more patients getting admitted to observation. We're starting to use the mobile van service. Our laboratory obviously is getting used for the testing. You can see really large variances in diagnostic imaging, X-ray, ultrasound, CT down here. You can see how much these numbers in the actual column are so much bigger than the budget in prior year. So obviously pharmaceuticals is a lot higher as well. And those are the departments that we've benefited from financially because of the higher, especially ER volume. Now, but I also wanted to point out that is not a leading indicator is to just look at gross charges for this line item number 4. Long-term care looks on the surface as if it's busier because we're showing more gross charges. But when you look at the detail, our volume is actually down 3% and our rates are up 18% in skilled nursing. So that doesn't always translate into higher payment because we don't normally get paid our charges, we get paid cost, and we get paid fee schedule on skilled patients. So the So it may be misleading if you come to the conclusion that our growth is in the long-term care area. It's more of a break-even situation at this stage early in the fiscal year. So I just wanted to kind of give you a picture of what's going on here and how we're doing the first couple months, but in general, I think we're off to a good start.
Very helpful, Dave. Very helpful. Thank you.
Any questions?
I don't have any questions, but I appreciate the line items listed because that makes it easier for me to follow, and then the summaries that you have. So I appreciate the work that you've done there. So
Thank you.
Thanks, David.
I've had 30 years to work on this, and it's you know, the one thing that's new for me is how to do Zoom reports. So I'm still learning that.
Well, your ability to translate very complex stuff into terms that laymen can understand is right on target. So thank you.
Well, thank you.
Yeah, it's looking good.
So I got to stop sharing my screen. Okay.
All right. Any other questions or comments for Dave?
No, just thank you for everything, Dave.
You bet.
Barbara can breathe a sigh of relief.
Till tomorrow. More to come. That's right.
Okay, I'll move on. Then on the agenda, there is no old business, so we'll move to item G, new business. And this is a resolution to proclaim a local emergency. And Scott, Tim, who's going to fill us in this one?
Let Scott do that.
Yeah, I'll go ahead and fill you in. I've taken care of all the spiders, so I'm good to go. So you may all recall prior to COVID, way back in the day, when directors would attend meetings remotely. Directors have been able to teleconference, video conference for several years now. That preceded COVID. But when you did that, you had to put the location from where the directors were participating from, and the public had to have access to those locations. Well, of course, with COVID, the governor issued an executive order that suspended those provisions in the Brown Act. So right now, we can meet remotely, and everyone could be at a different location, and we don't have to put those locations on the agenda, and we do not have to provide a physical location for the public to participate. And that was because of the social distancing that the government was promoting. One thing that did not change was we have always been required to allow the public to participate in the meeting. So we have our public comment section on the agenda. And then, of course, before the board takes action on any item or after reports, Ross will ask if the public has any comments. And in doing so, we are fulfilling our requirements under the Brown Act. So on September 30th, the executive order suspending those rules under the Brown Act expired, and the governor did not extend that executive order. However, the legislature amended the Brown Act, and in particular, Government Code Section 54953. And this is an amendment to the Brown Act that is in existence until 2024. And what it says is that if there is a state or local proclaimed state of emergency that requires some form or encouragement of social distancing, that local agencies can recognize this state of emergency, and they can adopt a resolution that will allow them to continue meeting remotely without having to post addresses for where directors are participating from, or have a physical location for the public to participate. Right, so there has to be a state of emergency. Social distancing has to be part of that. If those two conditions exist, then we can continue as we're doing now while encouraging and promoting public participation. If either of those two things go away, then we go back to the old rules where the agenda has to include the address for where directors are participating from, and the public has to be able to have access to those locations. So at this point in time, special districts have an option. They can choose to opt in to the amended provisions of 54953 and continue with the remote meetings, or they cannot opt in. And then we go back to the old Brown Act rules and we'll post addresses on the agendas, and those locations will have to be open to the public for meetings. At this point in time, because we're still in a state of emergency and the government is promoting social distancing, even if it's not necessarily required, they are encouraging it. My recommendation would be that the board opt into these alternative Brown Act provisions that have mirrored what we've been doing for the last year and a half until this state of emergency is over. The one catch is you will have to renew this resolution every 30 days. So
Can I make a motion that we opt in?
and I'm sorry, Gene, what was that?
Can I make a motion that we opt in?
Yeah, he's making a motion to go ahead and do.
Go ahead and opt in.
You want to adopt the resolution?
Yes.
Yep.
Thank you, Gene. Does any member of the public wish to be heard on this item before the board deliberates? Okay, seeing none, then we have a motion. Do we have a second and then discuss?
Gladly second, Ross.
Fred seconds. So discussion, questions, comments for Scott?
We don't have any choice. Or well, I guess we could have a choice, but the smart choice is to opt in.
Yeah, if it allows us to continue to do this, I'm certainly in favor of it. Scott, can we, if we continue to do this every month, is this something that can be on the consent agenda, or does it have to be a separate action item?
So I think that you can do it on the consent agenda. There isn't any legal prohibition. So we would just have to see if there's any public comment right on the item, but I don't see any legal reason why you could not.
Okay. Any other questions or comments before I call a vote? Okay, then Fred, your vote?
Yes.
Gene?
Yes.
Catherine?
Yes.
John?
Yes.
And I'm a yes. Scott, thank you for doing this. Appreciate you keeping us out of hot water.
Yep, thank you all.
I actually sent this on to Current Health Systems, Scott, and they were extremely appreciative because they totally forgot about it.
Yeah, great.
So I sent them your formula and your resolution, everything.
Good work,
Okay.
Scott. Thank you. Okay, item 2 is potential time change for regular board of director meetings. And this is an item that was brought up at our last meeting a month ago to be placed on tonight's agenda. So we haven't had a chance as a board to discuss this. And so have this on tonight.
You're breaking up, Ross.
Uh-oh.
You've been good all night until just that second.
So the purpose of having this on the agenda is so that we can have an open dialogue among the board members for us to decide if this is something we want to do or not. Just to doing this, certainly having staff do the work within regular working hours and not having to go into the evening hours is probably less expensive for the district and certainly more convenient for staff. For board members, all of you, I'm not speaking for myself, have regular jobs. And, so that's the downside is it's time away from your work on your other obligations. And there may be other reasons for not meeting during regular working hours. So as we discussed this in the governance committee, we didn't come to really any conclusions, but It appeared as though Wednesdays during the day seemed to work well for most of the people that had anything to say on this, except for Catherine. It didn't work well for Catherine because she works on Wednesdays, and that would mean more time away from her work. As we discussed all the other days of the week, there are reasons why the other days of the week were not advantageous either. So I don't know if this is something we want to approve, but this is our opportunity as a board to talk about this and decide which direction you want to go.
What about Thursday at 12 o'clock?
Yeah, there's a conflict there, I'm afraid.
You know, if we change it and there's an issue comes up that we didn't foresee, we can change it back, right? I mean, it's not.
It's not cast in stone.
It's an issue. Now, what about Catherine? Can we get her a different job? Catherine, are you there?
Yeah, I'm here. But I like my job.
No. Would you be able to do Wednesday at 12 o'clock?
Not for the time allotment, no. Unless you keep board meeting less than an hour, it's not gonna happen.
Can't do that, yeah, right.
Yeah, I mean, I work 2 days a week, Tuesday, Wednesday. And my job is a service to the public, women and children in need. So it's not something I am willing to give up. I try to work around my schedule as much as I can. I do work the first and third Thursday. So I'm working 20 hours a week. The rest of the time, you know, I'm available. But Mondays and Fridays are completely free to me. So, I mean, if it's not something that can meet everyone's need, then I'd like to apologize to the board, but I would prefer to stay where we've been meeting for, I don't know how many years, than to interrupt the job and the service that I provide to the community in my position.
But Catherine, let me ask you this. If we assigned you to a different committee so that you weren't losing time on the finance committee on Wednesdays, would that help at all?
Well, I changed my lunch hour to try to be on the finance committee. So
We want to keep you on the finance committee.
well, yeah, I'm not sure. I mean, I don't want to be a stick in the mud, but again, if I don't know who's capable of not being at their place of employment in hours, then I prefer to eat Monday or Friday, the second Thursday of the month, or leave it on Wednesday nights. And that's just my preference because of my employment, which again is a.
Really
What about
appreciate you sharing
Friday?
that information.
People always show up to work to get paid, so Friday would be a good day to have it.
Well,
Everybody-
you know, I know it's tough because, you know, there's 4-day weekends, there's Mondays or a
Yeah.
lot of holidays. Fridays are days sometimes people leave early to
Right.
go on a holiday. And I understand that, but I also, when I ran for the board, was a commitment to the board, not to vacation times or to sick time or any of those things. So I understand the need for those that would like to change it, and I'm all in favor. However, I need to have it fit into my time constraints, and sorry about that, but yeah, I've worried about it. I want to let you know that by requesting changes to be on other days during my work time has been a burden placed on me. It has put me in a place that I have worried about it. And I want you guys to understand that I value my position on the board. I want to continue on the board, but it has been a burden that I've been carrying for, you know, several weeks at this point. So You guys let me know what you want to do, and if you want to change it and I can fit into my schedule, I will do that.
Catherine, what time do you usually start?
8. I work 8 to 5.
I was trying to see if there was a way we could go to an early morning meeting. You know, before normal hours and stuff like that. I mean, for one day a month, you know, might be another option.
Monday.
Well, and like, that's what I said, like one day a month. I mean, I don't work on Mondays, any Fridays, or the third or last 2 Thursdays of the month. I don't work. So, I mean, there's other options to look at in those days, but I understand, I don't want to put a burden on those that have to provide the reports. And I don't want to put a burden on those that have to get things for payroll ready. I understand that all those coincide with one another. So, I mean, I know there's a lot to consider in the situation. But I guess my comment is, if we can't agree on a different, then I would prefer to stay where it is. It is what it is. So
Certainly an option. That's fine.
Hey, Ross,
Yes, Fred.
also note that for myself, the first Wednesday of the month, I also have a commitment from 11:30 to 1:30.
Okay.
It's a long term.
Okay.
Okay, thank you.
John, any thoughts on this?
Yeah, I'm usually pretty flexible, Ross. I mean, I know that there's, I've been in LA a lot more this last year, but if worst comes to worst for me, I can always get on Zoom or on the phone or something, which I've done in the past. I mean, but I can usually be pretty flexible with dates, but I also understand where Catherine's coming from. I know it's kind of between a rock and a hard place with her situation, so.
Gene, any thoughts on this?
Yeah, she's right. Friday and Monday would be definitely off because of the holidays. And so Thursday's definitely off. So there's not too many options. And with new people coming on the board, being available, I mean, most people can make the first Wednesday at 5 o'clock or 6 o'clock. And it seems like whoever started that maybe knew what they were doing.
Is there a way to move it up? Maybe we're not, because like I said, we didn't start till 6 tonight. Is there a way maybe that could get moved up? So
To 5, what time, Catherine, you get off at 5, she wouldn't have time to get here.
I do get off at 5.
a little time.
Yeah, we should, all of us think about it, and maybe the next meeting, bring it up again.
Well, and Barbara, what is your input? Because you have a lot to do. You and Heidi are the ones that do a lot of the reports. And have payroll to do. So I think a lot of it is in your ballpark as far as what flexibility that you guys, the two of you have. I know by the time we come to the board, we have pretty much covered in different committees everything that's coming to the board unless there's a change. So we already have the knowledge of what we're going to cover at the board for the most part. So is Mondays a hardship for you guys? Is it a hardship if it's like the second Monday of the month instead of the first Wednesday? I mean, it's what, 4 days difference? I mean, I don't want to put you on the spot, but.
Talking like in an afternoon meeting or like a 1 o'clock or something like that, or is that what you're talking about?
Yeah, in any time on the Monday, but if it's an afternoon and payroll's done in the morning, or I mean, I would love to accommodate everybody. It's just, I'm good at a lot of things and that is not one of it. Ask my grandkids.
Every other Monday is a payroll Monday, so that's just a timing.
But if we did it
Okay.
the day, like 1 o'clock or something like that, where we focus most of our payroll stuff in the morning or whatever. I mean, Heidi, this really hits you hard.
Other payroll days that land on holidays and you see them coming on the calendar, you have to
You
make
work around them.
adjustments. and So you can work around them.
Yeah.
To do a Monday morning meeting would be quite difficult.
Right, that's what I'm not
But-
suggesting that.
Anything from like 1 o'clock on would be fine.
Okay, so maybe 1 o'clock on Mondays. How's that work for you guys?
Well, what are you gonna do on a holiday if you get a holiday?
Right.
We'll
there's
just
a
have to
lot of
work around it.
holidays.
And with
People
some
wanna
of
go
those,
out.
like holidays sometimes fall on the day that the board meeting would be, like January 1st.
Right.
It's still considered a holiday, and so we make adjustments the month before.
Right.
Which we may have to do from time to time, but
Right.
it's not impossible.
The board meetings can last 3 or 4 hours from time to time.
They
When it-
can. What does a Monday afternoon do to you, Fred and Catherine?
I
In
am,
general, when I know in advance, I can plan accordingly for it with my people.
Okay, I'm sorry, Catherine, go ahead.
yeah, and like I said, on Mondays, I don't work. I mean, yeah, there's times I'm off on vacation or gone to do something else because I usually have a 4 or 5 day weekend. But I am willing to commit to a Monday 1 o'clock. You know, and especially right now with Zoom, if we're doing it, I mean, the reason I am not at the board meeting tonight is some of my family has been tested positive, so I'm quarantined, you know, and having to work from home, or I would, you know, be there. And that could be something that could happen in the future. I mean, I can't foresee any of that, but I definitely could commit to a Monday 1 o'clock, whether it's the first Monday or the second Monday. It's like a 5-day difference. So
Okay. Jean and John, any difficulties with that?
No, Monday would be fine with me. We could try it.
We're looking for the second Monday because of the timing of some of the meetings, Heidi. Would that be better, the second Monday?
Well, because most of the reports feed through the committee schedule is more critical.
Right,
But
that's
you
usually the
just
week
need
before.
Posting time for
Right,
the board.
Right.
So you could either do the Monday following finance, or you could do a set Monday each month. I just don't want to create too much of a delay between the committee meetings and the board, because the board does the final approval for a lot of things that are tied up in the committee.
exactly.
Hey, Ross,
Yeah, Fred.
looking at the calendar, we might want to consider putting something to the effect of the Monday following the first, just in case the first is on that first Monday.
that makes sense.
So to give you an example, November would be on the 8th, December would fall on the 6th, January would fall theoretically on the 3rd. But due to the holiday of New Year's, we could push that if we needed to, so on and so forth. It's really just whatever works for everyone here.
I prefer not hitting the first. There's too much that happens in
Second.
our areas for closing out the month and starting the new month.
Right.
on
No,
the
that's
first.
why I was saying that Monday following the first.
Yeah, second Monday.
Well, if everybody's agreeable, I definitely would like to try it. I mean, we're not going to know until we, until we do try it, because there's always something that could come up.
Do
And if
you
it
need a
doesn't
mo-
work, we fall back.
do you need a motion to change it to Monday at 1 o'clock, second Monday?
So you're going to need a resolution. If you
Okay,
would like to do it for the month of November and schedule it as a special meeting, you can, and we will have a resolution that the board can adopt, but the day, time, and location of your meetings is set by resolution.
Okay.
So it could be done, but that resolution can be heard at the next building and planning committee.
Yes, that's
That's
correct.
a full meeting of the board.
Yep, absolutely.
Don't have it that day in November, it would just be posted as a special meeting, not a regular meeting.
Right.
Yep, you can do that too.
okay.
So that would make our November meeting on the 8th, correct?
Correct. That's what I'm showing on the calendar.
At 1 o'clock.
1 p.m.
Okay, well, any objection to giving that a shot? Well, we'll set it up as a special meeting for November 8th.
Works for me.
And then we can get feedback from everybody at that time on if we think this might work, and then we can move forward with a resolution after that date, after that meeting.
I'm good with it.
Yeah.
I'm good with that. And thank you very much, because I know that I probably didn't come across very nice, and I usually try to be. I just I just want it to work for everybody, and maybe especially me. Oops, sorry.
Absolutely. Thank you, Catherine. You were fine. No worries.
Okay.
You're normally not that ornery.
I know. I know. Sorry about it.
I've been hanging out around Gene too long. We understand.
It's true statement. It's true statement.
Tim, Heidi, and Barbara, you think this is workable?
It's certainly worth trying. Yeah, I think so.
I think so.
Okay. All right, let's plan on meeting November 8th.
So is that,
And
do we have a vote for that?
designate that as a special meeting.
This is an action item.
That's an action item, so we need a vote.
Okay, so we'll need a motion and a
On
second.
me, Scott.
Right, you're muted.
You guys don't have to take action to set a special meeting on November 8th. The
You don't?
president has the authority to call special meetings. If you want to, you can, but the president has authority to call special meetings. If Ross says our next meeting is Monday, November 8th, then you can meet that day.
Have to cancel the November 3rd meeting. That's a standing. And how do we do that?
Heidi will just post a notice of cancellation.
Okay.
You can do a motion if you'd like, but it's not required.
Yeah, I since it's not required, then I won't do it, and I'll, as president, call a special meeting for November 8th and cancel our November 3rd meeting.
There's also Dr. Finstad to consider.
Monday afternoons are generally good for him,
Okay,
but I'll touch bases with him tomorrow just to make sure.
Yeah, he's usually here in the hospital anyway, so.
Thank
on
you.
Monday, that's right.
For purposes of the resolution, is it gonna be the second Monday of every month or the first Monday after the first of the month?
Yes, the second one, the first Monday after the first.
Yeah.
Okay.
Because sometimes the first will fall at a weird time and it pushes it too far down into the month.
Right.
Okay, gang. Then thank you. Thanks for that discussion and your candid input on that. It makes us work better as a board. I think this is worth trying and seeing if the advantages of it outweigh the disadvantages. So thank you.
Yeah, thank you.
So item H, director's comments that are for items not appearing on the agenda. And Fred, we'll start with you tonight.
Dave, I just wanted to say thank you for the reports. The clarity and the way that you present them makes things much easier for all of us to understand, and it's appreciative. And to all the board members, guys, it's always nice when we can talk things out smoothly and make things happen. So thank you for that.
Thank you so much.
Gene, any comments tonight?
That new meeting deal, it'll be easier to stay awake during the meeting. And David, you are making an effort to make it so we can understand better. Thank you.
You bet.
That's about it.
I couldn't have done it without Barbara's help. She's been such a huge, all the foundational reports that she has and all the help that she's given me in learning your systems has been invaluable.
I was referring to her about staying awake during the meeting.
Oh, Gene.
Who's
Yes,
next?
Ross is locked up.
Comments? My,
Your picture's locked there.
Yeah, we lost him. How can a media come?
Your meeting minutes, right? Catherine.
I just want to thank you for lots of things. First, David, for your report. It does make things easier, like I had mentioned earlier. But I also want to give kudos to Barbara and Heidi. I mean, they've been doing this a long time, and I think they are the reasons that these meetings run as smoothly as they do, and we look as good as we do because they allow us the information to go forward as we need to as a board, and I just appreciate that.
I think Ross is trying to get back in, but I'll go ahead and do my comments. I just had a few things. Dave, once again, welcome to Kern Valley, and thank you for everything that you're doing to help Barbara out in this situation. And to echo what the other board members said, the reports are very clear and concise, and it's a lot of new information to absorb. And again, like I've said in all the previous meetings, thank you to the staff and everything going on with COVID, obviously. You guys have been doing a phenomenal job. I did go to the Crab Fest a few weeks ago, had a good time. It was a really good turnout out there. I'm just disappointed that I did not win the Mexico vacation, but I came close. And just real quickly on a kind of a somber note, I wanted to say this in my comments. We had two people that recently passed away in the Valley. That was Joe Cirillo and Chuck Wild. Joe never served on this board, but I think at one point he had considered being appointed. He was very active in everything in the Valley. And, Chuck Wild served on this board for, I think, 14 years.
Yeah.
He went through kind of the rough time when the hospital almost was on the verge of bankruptcy. But I just wanted to acknowledge, all of their support and their dedication to Kern Valley Healthcare District over the years.
And to the community.
And to the community. Yes,
And the foundation.
and the foundation, they were both very involved with the foundation too. Yeah, they were also both past recipients of the Man of the Year Award from the Chamber of Commerce, and they were both longtime Exchange Club members too. So I was kind of shocked that they both kind of passed away back to back. But anyway, just wanted to mention that.
Thank
Hey
you.
guys, I'm back. Thank you for those comments, John.
Yeah, thank you for that, bringing those two men up. Thank you, John.
You're welcome.
Yeah, my internet connection went out. Sorry about that, gang.
You're up.
Okay, I don't have anything to share. I want to thank you for a good informative meeting, and things obviously our leadership and our staff are taking care of things within the district. We're doing a very great job, and I appreciate all your efforts. And we will meet again on November 8th. Thank you all.
Have a great evening, everybody. Be safe.
All right, take care.
There's a spider behind you.
Spider-Man.
That video.
Yeah,
He's a little blurry though.
This is a public taker. So.